So good afternoon, everyone. I'm Yvette Kelly with the Community Technical Assistance Center, and I'd like to welcome you to our webinar today, Clinic Standards of Care Anchor Element with Treatment Planning Regulatory Changes. Today, I'm joined by my colleagues, Boris Vilgorn and Brianna Gonsalves and Connor McCollum, along with several of our state partners from the Office of Mental Health, including Kelly Hausler and Bonnie Catlin, who we'll hear from shortly. Before we get started, I do want to take a few minutes to review some logistics. If you're wondering if you will have access to the slides from today's presentation, the answer is yes. Both the slides and recording from today will be made available and posted to our website, ctacny.org, within 2 to 3 business days. So anyone who'd like to refer back to this content at a later date will be able to do so. We also recommend that you pull up the Standards of Care Anchor Element documents to follow along during today's presentation. And if you are unclear as to where to find them, if you look in the chat box, you will see a link there where you can access them. Upon joining today, all participants have been muted. However, we will devote some time at the end of today's presentation for Q&A, so we are asking participants to please submit any questions that you have utilizing the chat box, which is located on the bottom right-hand side of your screen. We do ask that when chatting, if you could please use the drop-down box to chat to all panelists, that would be appreciated. Just make sure that everyone is able to see your questions. Please note that this presentation does not serve as official guidance, and details contained in this webinar is informational only. We do ask that you please refer to Part 599 and the Clinic Standards of Care Anchor Element documents for official guidance. Next slide. So here's a quick look at our agenda for today. We will begin today's presentation with an overview of our purpose, briefly review the treatment plan regulatory changes, and then move on to discuss the changes to the treatment plan standards of care. Again, we will then open it up for questions before concluding with some next steps. Next slide. So as we spend the next hour talking through some of the updates to both the regulations and standards of care, we thought it would be helpful to provide some context as to why these changes were considered and subsequently implemented. As you're probably aware, over the years, MCTAC has had the opportunity to facilitate a number of conversations between OMH and clinic providers with the goal of understanding how service delivery can be improved. And this has been a consistent focus. And so that being said, these changes reflect the priorities of the commissioner and signals a shift towards quality that is codified in both regulations and the standards of care. These changes also support a shift towards greater flexibility for providers to develop practices and protocols that lend themselves to providing care that is driven by current clinical presentation rather than administrative requirements. This flexibility also translates into mental health professionals utilizing their expertise to develop plans that change and grow and are as varied as the needs of the individuals they work with. Lastly, it's also important to convey that licensing was an integral part in the revisions and changes to both the treatment plan regulations and the standards of care. Next slide. So before moving forward in the presentation, I think we'd like to hear from all of you in regards to whether or not your agency has transitioned to the new treatment planning regulations. So if we're going to you're going to see a poll in a minute. If you could please just take a moment to complete that poll, that would be appreciated. It does take a few seconds for us to get the results in. So if you just take a moment and complete that, be helpful. Should be getting the results here in a minute. It's another few seconds and we should be able to see the results. Okay, so the results are in. So it looks like some of you have transitioned. There are a number of you who are, I think, still debating or not sure about whether or not you're transitioning, and some of you who are not, and then have partially implemented the new treatment plan regulations. So thank you for those results. For those of you who've indicated that you've not implemented the standards or you've um, have only partially implemented them, we'd love to hear from you regarding any barriers you're experiencing. So please feel free to utilize the chat box to respond to that question as to why you have not transitioned to those new standards. And thank you all for your responses. Next slide. So the next part of the presentation is intended really just to provide a brief overview of the changes to Part 599 treatment planning regulations that went into effect August of last year. Again, no new changes in this section, but just a quick review of some of the information presented in prior webinars. Next slide. So here's a summary of the updates that were made to the Part 599 regulations, again, which I assume most of you are familiar with, but just as a refresher, these updates included clarifying the difference in requirements between Medicaid fee-for-service beneficiaries and those of other payers and plans, removing the discharge criteria from the contents of the initial treatment plan, reducing minimum requirements of treatment plan reviews from 90 days to no less than annually, and providing agency autonomy for the documentation of the treatment plan. And lastly, clarifying the physician signature requirements for treatment plan reviews and updates, as well as the requirements for the individual's and family's signature. Next slide. Yeah. So one of the areas in which there are differences based on whether the individual is a Medicaid fee-for-service beneficiary or a beneficiary of another payer or plan is the signature requirements for the initial treatment plan. For Medicaid fee-for-service beneficiaries, the plan must be authorized or signed by a psychiatrist or other physician. For beneficiaries of other payers and plans, the initial plan requires signature by a psychiatrist, other physician, or psychiatric nurse prescriber if medication is a part of the treatment. If medication is not a part of the treatment, then in addition to those just described above, the signature of a licensed clinical social worker or other licensed practitioner is allowable. Slide. Again, as mentioned earlier, the discharge criteria has been removed as an essential requirement for the initial treatment plan. This was done to allow for more of a focus on goal attainment versus focusing on the criteria needed for discharge. Additionally, the due date for the initial treatment plan was revised. For Medicaid fee-for-service beneficiaries, the initial treatment plan is due within 30 calendar days of admission. For Medicaid managed care and or other commercial payers, due dates are determined by that plan. And if there is no requirement by the plan, then the due date defaults to 30 calendar days of admission. Next slide. So one of the most monumental changes to the treatment plan review regulations is that of the timeline change. Previously, treatment plans were due every 90 days. However, with the revision, the timeline has been amended to no less than annually or more frequently as determined by the treating clinician and the individual or family. So again, just to reiterate that while the minimum requirement is no less than annually, it does not prohibit clinicians from completing treatment plan reviews more frequently. The timeline of annually is based on the admission date or the most recently completed treatment plan review thereafter. Next slide. So there were changes to the treatment plan update signature requirements for Medicaid fee-for-service beneficiaries. A signature is required when new services are added, the service intensity is increased, and or as necessary and determined by the clinician. Again, this applies to only Medicaid fee-for-service beneficiaries, and for all others, you will need to consult with the payer or plan for their signature requirements. Next slide. For the category of all other changes to the treatment plan, and you can see some examples noted here. These changes can be completed within the progress note, meaning a full treatment plan review is not required and only the signature of the clinician is needed. So again, you can all other changes only requires that of the clinician. Next slide. And lastly, there were revisions to the requirements for recipient signatures. Signatures of the individual and family are no longer required. However, there should be evidence of their participation in the record. The emphasis here is on the demonstrated participation of the family and or individual throughout the course of treatment and is not just limited to the signature on a treatment plan. Additionally, it should be common practice to offer individuals access to treatment planning documentation, which can be helpful in ensuring, again, that the participant and provider are on the same page. So that's a quick review of the treatment planning regulatory changes. And with that, I'm going to pass it over to Bonnie and Kelly to walk us through the remainder of our presentation today.
Good afternoon, and thank you, Yvette. Next slide, please. Standard of Care Focus 2.11. Every recipient has a person and or family-centered treatment plan that is developed with input from the recipient, family, collateral, and supports as appropriate. The old 2.12 section was combined with 2.11. We removed 2.12. We removed the word comprehensive to promote more focused treatment plans. Comprehensive treatment planning may overwhelm the individual and family and may contribute to clinician burnout. Treatment planning may be incremental or sequential. Instead, more focused and specific treatment planning may better align with what is happening in session. Planning can be as simple as 1 or 2 goals with 1 or 2 objectives per goal to better align with the desired priorities identified by the individuals and families. We also fleshed out the terms individualized and person-centered. We understand that there are various interpretations of the terms individualized and person-centered. We replace those terms with more specifics about what we are looking for and are amplifying the message in order to make a significant change in practice. We also added language to reflect family-centered. In addition, we added language to ensure that treatment planning reflects individual and families' preferences and priorities. Goals, objectives, and services should align with what the family and individual prefer to work on according to their priority. Preferences and priorities are also informed by the stage of change. While there may be multiple needs identified, prioritizing goals may contribute to a more positive treatment experience for the individual and family. We also added language to defer identified needs which do not align with the current individual and or family's priorities. The therapist should document the rationale for deferral, for example, not interested in this area, working on it with another provider, etc. In addition, we moved participation of individuals and families from exemplary 2.12 to adequate 2.11. Signatures by the individual and family are no longer required by regulations as evidence of participation. This will be addressed in a later slide. Instead, documentation demonstrates that treatment planning is co-authored by the individual and family. Rather than stock statements such as X participated in treatment planning and X agrees with the treatment plan, using actual language from the individual and family. For example, written quotes and written comments show evidence of individual and family participation. We removed no boilerplate treatment plans from the needs improvement column. However, if a treatment plan is truly co-authored by the individual and or family, that will decrease the likelihood that it will focus on adherence or compliance or will be a template type of treatment plan. Instead of seeking treatment plan approval, elicit feedback all throughout the term, emphasize the collaborative process over the completion of the document. We also move discharge criteria from adequate to exemplary. Discharge criteria is no longer a regulatory requirement on the treatment plan. The intent is to distinguish discharge criteria from discharge planning, which may have become conflated. Treatment planning still includes the initiation of discharge planning as appropriate. The practice of discharge planning includes working toward goal achievement, desired outcomes, and treatment completion. This remains an important part of the clinical process all throughout treatment. Kelly?
Thanks, Bonnie. Hello, everyone. The concept of discharge criteria has raised questions, especially in adult treatment, about the need to transition all individuals from clinic to their PCP. However, there's a range of clinical needs. Some individuals may be appropriate to transition to their PCP, while others may continue to require clinic treatment as a specialist service. For example, we don't insist that individuals with diabetes transition from their endocrinologist to their PCP for diabetes management. Instead, we emphasize individualized treatment planning focused on outcomes defined by the individual. Next slide, please. And Bonnie, over to you.
Thank you, Kelly. Aspects of the old 2.12 section were embedded into 2.11, and we removed 2.12. The goal of this change was to reduce overlap. We expanded those who may be involved in treatment planning to include other identified supports in 2.11. The intent is to acknowledge that all input according to individuals' and families' preferences, for example, family members, collaterals. Again, we acknowledge that this term is used in different ways, and other identified supports. We also added a new item to exemplary 2.11, and this is including provider input in treatment planning. The goal of this addition to exemplary was to reflect input from community providers. This also includes the referral sources according to the individual and/or family's preference. We removed the term strengths. The term strengths was removed to avoid duplication of an assessment standard. We continue to value strength-based treatment planning, which is more likely to instill hope and produce favorable outcomes as opposed to deficit-based treatment planning. Next slide, please.
Standards of care. Yes, thank you. Standards of care focus 2.13. The initial treatment plan is developed according to regulatory requirements. We moved the old initial treatment plan section 2.31 to the new section 2.13, and we did this to allow for better flow. We clarified calendar days and removed or prior to the fourth visit. We clarified that the initial treatment plan is due 30 calendar days from the admission date or according to the payer. We removed the option to be due prior to the fourth visit since it resulted in frequent questions and confusion, though that's less relevant anyway due to the removal of the individual and family signature requirement. If there are missed sessions, the initial treatment plan may still be completed, built on what information is known, especially if there is discussion about goals at each session starting at intake. It's okay, actually even preferred, if the plan is not comprehensive. It will evolve naturally as we get to know the individual and family. The plan may be preliminary based on early identified needs. For instance, the individual's and family stated needs, risk-related needs, immediate medication needs, etc. And there's no change in initial treatment plan provider signature requirements. Over to you, Bonnie.
Thank you. We removed the regulatory requirement for individual and family signatures on treatment planning documentation. Signatures by individual and family are no longer required by regulation as evidence of participation. Historically, the parent and guardians signature has been evidence of participation, and in some clinics, it is served as consent for treatment. Agency policy should indicate where and when consent for treatment will be documented by the parent, guardian, or other person who has legal authority to consent to the health care on behalf of the child, as well as the child's signature where appropriate. There are no exemplary items within this standard. Next slide, please. Kelly?
Thank you. Standard of Care Focus 2.14. Treatment plan reviews reflect ongoing appraisal of progress and lack of progress towards all goal or goals and objectives. We changed the timeframe requirements to reduce administratively driven documentation and focus on treatment versus the chart. However, no less than annual treatment plan reviews does not mean annual treatment plan reviews. Given that the treatment plan reviews are more clinically driven, there may still be frequent clinically driven reviews, depending upon the current clinical presentation. The timeframes are individualized. Treatment plan reviews are a methodical appraisal of all goals, objectives, and interventions. Progress is appraised from the perspective of the clinician as well as of the individual or family or collateral or support. We also emphasize the need for treatment plan reviews when there are significant clinical changes. Treatment plan reviews are required to address significant clinical changes. So for instance, a change in behavioral or medical diagnosis or condition, risk level, increased or new symptoms, functioning, stressors, needs, circumstances, etc. This is not a complete change, but we are amplifying the message in order to make a significant change in practice. When there are significant clinical changes, such as a hospitalization, an increase in symptoms, a new medical condition, the death or illness of a family member, the loss of a job or income, etc., then reviews may be more often. When an individual receives medications-only treatment, there may be fewer significant clinical changes, so reviews may be less frequent. This will allow treatment plan reviews to serve as a clinical tool to address changes in the clinical presentation in real time. We changed the signature requirement. The clinician's signature is the only required signature. The change in the regulatory signature requirement is to provide flexibility, not to diminish the role of the psychiatrist. We still seek meaningful treatment team collaboration, which is documented in a progress note. And the exemplary item was changed from ensuring that the treatment team had access to the record to ensuring that treatment teams collaborate in case discussions, and that may result in changes to the treatment plan. Next slide, please. Standard of Care Focus 2.14.1. Treatment plan updates reflect service increases and are made timely in accordance with the recipients and families' changing needs, as are all other treatment plan changes or adjustments. So we're distinguishing the concepts of treatment plan review versus treatment plan update. We're recognizing the distinct meaning of each term in order to be clear about the regulatory requirement differences. So we've covered treatment plan reviews already. So now we'll talk about treatment plan updates. Regulations require treatment plan updates when there is a service increase. So for instance, an addition of services or an increase in frequency and or duration of services. It's not for service reductions. Regulatory language specifically uses the term update. And the language is treatment plans shall be updated when new services are added, service intensity is increased, etc. During the August webinar, we required a full treatment plan review when providing a treatment plan update. The process has evolved, however. Providers can operationalize their own treatment plan update process. While treatment plan reviews and treatment plan updates may use a similar clinical process, the signature and timeframe requirements differ. Treatment plan update signature requirements are the same as the initial treatment plan signature requirements, depending on payer. We introduced all other changes. In the past, some clinicians may have waited to make changes until the next 90-day review. Now, all other changes may be made in real time as the current clinical presentation changes and or as progress is made. So for instance, a change to a goal, objective, intervention, time period, or staff. A change in individual and family preference or priority may stimulate these changes. Therapists may use clinical discretion to identify the need for treatment plan changes when there is minimal or no progress. All other changes require clinician signature only, which is an area of documentation flexibility. We emphasize the need for the ongoing collaborative process. All treatment plan updates are made with input from the recipient and family. This emphasis on the collaborative process also applies to treatment plan reviews. And as in treatment plan reviews, the exemplary item was changed from ensuring that the treatment team had access to the record to ensuring that treatment teams collaborate in case discussions. Next slide, please. This slide simply represents that we moved the old initial treatment plan section 2.31 to the new section 2.13, and we removed 2.31. Next slide, please. And over to you, Bonnie.
Thank you. We also added footnotes to the Clinic Standard of Care Anchor Element document. Footnotes include signature requirement information for provider convenience. They also include the requirements for agencies and programs to develop a policy that identifies the location of treatment planning documentation. Treatment planning documentation may be maintained in the treatment planning section or in the progress notes section of the case record, as long as the policy identifies where the documentation will be maintained. Treatment planning documentation must be easily identified in the EMR and case record. Ensure that all program staff as well as OMH licensing staff can find treatment planning documentation. Next slide, please. Due to the scope of this webinar, slide 21 and 22 are for visual reference only. Providers may consult the revised Clinic Standards of Care Anchor Element document for further review. Next slide, please. And next slide, please. And Kelly, over to you.
Thank you. These key takeaways are items already covered in today's presentation. However, they may be helpful for program supervisors to alert clinicians, for instance, during a staff meeting, to the biggest changes in the Clinic Standards of Care Anchor Element. So slides 23 through 25 are for visual reference only. Next slide, please. And next slide, please. And next slide, please. Yep, thank you. And next slide, please. So thank you for sharing your questions before the webinar. In the interest of time, we did not answer questions which were outside the scope of the webinar. Please resend those questions and any additional questions to OMH using the contact information on the next slide. Only treatment plan related items were changed in the standards of care. Some questions that were presented and answered. Question number 1, would a clinic be permitted to write treatment plan methods as a range of frequency? For instance, individual psychotherapy, 1 to 3 sessions per week by primary clinician. And the answer, projected frequency should be individualized based on need. As always, documentation must demonstrate medical necessity, and especially for that level of acuity. Question 2, can a clinic write method with the frequency or duration as a monthly total time? For instance, individual psychotherapy session by primary therapist 3 hours per month. And the answer, please include both frequency and duration as per CMS requirements. The next question, how do the reg updates regarding frequency and treatment plan updates align with requirements for commercial insurance and CMS? Also, is CMS on board with the new treatment plan standards of care? And the answer, for commercial insurance, please consult the commercial payers for treatment plan requirements. Our updated regulations were developed in alignment with CMS requirements. The next question, I am puzzled by the category other changes. Can't we just do a treatment plan review to document changes in anything such as staffing goals, objectives, etc.? And the answer, Certainly, a treatment plan review is acceptable to address all other changes, but the intent was to decrease the documentation burden. So that would be more than is required to address a change in goals, objectives, interventions, time periods for achievement, and staff. The next question. Oh, one more piece I wanted to add that relates to that. Please note that wherever possible, it is helpful to align the naming and documentation and the EMR with language used in regulations and standards of care. So for instance, naming as initial treatment plan review, treatment plan update, and all other changes. That language is taken from regulations and standards of care, and it allows OMH licensing staff to more easily find needed items. The next question, 2.11 states, developed with input from the recipient, family, collaterals, or supports as appropriate. Please specify what needs to be documented if there is no collateral identified. And the answer, documentation may reflect that there is no collateral identified. And the final question, could you please talk about collaterals, their role in treatment, and when they should be listed within a treatment plan? There seem to be many questions about who, outside of family and or significant others, can be considered a collateral, for instance, teacher, school principal, care manager. I've also heard that as long as the individual is listed as a plan participant in the treatment plan, that person can be considered a collateral. So the answer, I'll share the regulatory definition of collateral as well as the regulatory explanation of the role of collaterals in treatment planning. Collateral means a person who is a member of the recipient's family or household or other individual who regularly interacts with the recipient and is directly affected by or has the capability of affecting his or her condition and is identified in the treatment plan as having a role in treatment and or is necessary for participation in the evaluation and assessment of the recipient prior to admission. A group composed of collaterals of more than one recipient may be gathered together for purposes of goal-oriented problem solving, assessment of treatment strategies, and provision of practical skills for assisting the recipient in the management of his or her illness. The role of the collaterals in treatment planning. Recipient participation in the treatment planning process, including initial treatment planning and treatment plan reviews, shall be documented by notation in the record of the participation of the recipient or of the person who has legal authority to consent to health care on behalf of the recipient, or in the case of a child, of a parent, guardian, or other person who has legal authority to consent to health care on behalf of the child, as well as the child where appropriate. The recipient's family and or collaterals may participate as appropriate in the development of the treatment plan. Collaterals participating in the development of the treatment plan shall be specifically identified in the plan. And finally, our FAQ also references the community provider as a collateral. Over to you, Boris.
All right, thank you, Kelly and Bonnie. So now we're going to move towards the Q&A portion from the chats that folks have been sending in. So I really appreciate, we've gotten quite a few already. Please keep them coming, the questions and comments. Excuse me. So before we actually get to some of the questions that we have received, just a couple of comments. I think overall we got to Yvette's question in regards to letting us know why some folks haven't had an opportunity or ability to implement some of these changes. So there were a number of comments that we received on it, but one that jumped out at me that, in general, I think for some folks, it's a little bit more complicated than others, especially for folks who have multiple license programs, maybe through OASIS and other types of licensing. So they need to make sure it aligns not just with OMH, but other state entities. And I think, the other one was also, and Kelly, I think you addressed a little bit about it, but individuals who have multiple payers like commercial insurance, Medicare, and other payers that are outside of Medicaid or Medicaid managed care. And again, I think those providers are looking to see how best they can align these new rules from it. So again, I think some folks that haven't implemented it seem to need to do a little more work to trying to figure out, since they have a broader array of individuals, both from payer side and regulatory oversight. So I just wanted to mention about those comments that we received, and again, I appreciate folks, bringing those comments in. So let's jump into some of the questions that we got. We have a couple of questions in regards to other licensed practitioner, and specifically questions about, can treatment plans be signed by LMHCs and or LMFTs? And also, if OMH can clarify what other licensed practitioner criteria means. So that also includes an LMSW under supervision. So a number of questions around that. So I kind of lumped them together. So I apologize, Kelly and Bunny, but any thoughts or suggestions around that?
Sure. It may be helpful, Boris, to pull up one of the treatment planning slides from the early section, especially the one that talks about the initial treatment plan signature requirements. So the phrases that allow for other payers. So as you said, anytime that there's a commercial insurance or Medicare, we're encouraging providers to consult with those payers and clarify their requirements. Yeah, this is exactly the one. So, and this has not changed. So this initial treatment plan signature requirement has not changed from before. So, so it really defers to the other payer. And then there's another slide, I believe, that talks about with medications or not. And so that part is the same as well. And then I'll also speak to, do you see that? Yeah, exactly. Yeah, perfect. So these are still the same. So, when you are using any of these that are listed down below for managed care, Medicaid, or commercial, so those still apply just the same as it's been all along. And we know that a lot of providers use, one most conservative approach because it's just easier for programs that way. So we've heard that from many programs. And I think there's one other comment I can make on it, and others might have more feedback. We haven't changed any requirements or definitions about what is allowed in terms of permits or professional staff. So all of those regulatory definitions relating to professional staff. So we haven't made any changes in the regulations regarding that.
Got it. So that the last piece that says other licensed practitioner, because I think that's where some of the questions came in. What you're saying, Kelly, has not changed from before. So whatever the rules were around LMHCs and other licenses and MSWs, and so forth, remain in place. Okay. Great. Thank you. Just wanted to clarify that. Okay. Let's move on to the next question. So I just wanted. So what is considered a significant change for a treatment plan review? One of the questions we got.
Yeah, so we gave a bunch of examples. And so if you, let's see, it might be more just in my notes, but one thing for the providers to know is you will be getting a copy of all of our notes in addition to the slides. So we are, sorry, what was the question again? I just lost track of.
So in regards to significant, it's okay. Significant change. Yeah.
Yep. So we gave examples related to that, and it's not a big change. The current standard of care also gives a few examples, like functioning and needs and circumstances. So we wanted to really give some similar examples, but maybe a little bit broader, and really emphasize that we've been wanting these reviews all along for those types of changes, those types of clinical changes. But we're really asking for it in a little bit bigger way and in a different way because we really do want to make a change in this. So the examples that we give, behavioral or medical diagnosis or condition, risk level, increase or new symptoms, functioning, stressors, needs, circumstances, etc. So, and don't forget the etc. Like you can fill in, we're using a lot of clinical discretion. And some other examples that we gave are if there's a hospitalization, an increase in symptoms, a new medical condition, the death or illness of a family member, the loss of a job or income. So those are all under the, just to get you thinking about what those significant clinical changes could be. We're looking for a treatment plan review. So that's the part about, you know, and no less than annual does not mean annual.
Right. Right. No, I appreciate that. And in the same, I guess, vein or in the same area, there's just a clarification. I think I'm getting a little feedback. There was a discussion about, you know, when there's increases to intensity or frequency and duration, would the same apply, meaning what you need to do around treatment plan, if there were decreases in intensity, frequency, or duration, or is it only about when things increase versus when things decrease, or are those equal?
CMS really plugs into the services, that frequency, duration, you know, as I think the person who asked the question, asking about that intensity. So we're not looking for the treatment plan update when there's a reduction.
Got it. So it's only about the increase, really. Okay. Thank you for that. So another question, I guess, a little nuance here, you know, and I know folks do experience this. So if the medication is prescribed by a provider that's outside of the agency, right? So they're not working for you. It's a, you know, maybe another agency or private psychiatrist or nurse practitioner. Would the signature requirements still apply in the same way when the clinic does treatment planning, or and especially if it's a managed care recipient? So if there's any differences between, you know, a psychiatrist who works for the same clinic versus a psychiatrist who doesn't?
I think I know what that question is about. Could you go to that other slide where it talks about the non-licensed professional? So when it depends on the payer, but then if there's certain times that you need the signature, if someone is on medications versus not on medications, if I'm following this correctly, the question is, what if the person's getting medications from another agency? So
Correct.
I would just continue, others might chime in differently, but I think I would still just continue to interpret the regulation as is. Yep. Oh, yeah. Yep. You got it. So, so if medication is prescribed, or if no medication is prescribed, I would still be interpreting just literally from the regulations.
Okay, got it. Thank you for that. There was a follow-up, I guess, you know, talked about, you know, private insurance and CMS. We had one question about OMIG. And the question is OMIG agreeable with all these signature requirements, especially around no prescriber signing and so forth?
So Boris, you're
Hello? Kelly?
Yeah, I think we lost. Kelly, I think we lost your audio.
Let's see. Looks like Kelly might have gotten disconnected from the audio. Hello?
This Boris, this is Stacey Hale. I
Yeah.
can jump in here.
All right, thank you.
Great question, and I'm actually kind of scrolling through the chat box while you're asking questions, and I know there was a couple questions about CMS and OMIG. So just to kind of give you a basic, quick overview. So CMS federal regulations are based on the clinic treatment option right now. And so any regulations that we have done within New York State for clinic are based off of those regulations, because we as New York State have to follow those regulations. Often what you end up seeing is that New York State regulations might be stricter than CMS regulations, but we cannot make more allowances outside of the federal requirements. So it is in a line with CMS, and OMIG works off of the regulations for New York State. And so we will be meeting with them to review those changes, to add for their audit tool, or make some recommendations for those changes. So that will be occurring. And right now, the reason we haven't completed it yet is because there will be some additional changes that we'll be making as we move hopefully towards the rehab option. And technically what OMIG is auditing right now is back several years. So they have not yet caught up to audit of changes that have occurred since August. So we will be meeting with them to make sure that they're aware of these changes in the regulations. But the regulations are what guide them in their work as well.
Excellent. Thank you, Stacy, for that. Just wanted to see, I see Kelly's still logged in. Hopefully we'll be able to hear you, but maybe others can jump in as well. So I guess one question folks are wondering, so there are currently planned OMH recertification audits that are in place, and got a couple of questions on just confirming that those audits that are already planned will start using these new regulations and these new standards of care.
So thank you. So the regulations have been in effect as of August. So even though the standards of care were not updated in writing, during licensing visits, staff were aware of these changes. So at any time between that August timeframe to now, if changes have been made, the licensing staff will be aware of that and make sure that they're using those regulations to support the work they're doing. The standards of care just helps to further support that so that the auditors are specifically looking at these areas, and we're helping hopefully providers to identify how we might look at it differently in relation to these regulation changes. So even though today, if the licensing staff showed up, they would, you would be able to have already adapted the regulation changes. The new standards of care will just really help support that and will officially begin being used by licensing staff as of July 15th. So we just wanted to give a little bit of time from presenting it to you all for digestion, for licensing staff to start to work it into their audits as of July 15th. But like I said, however, the regs have been in effect since August, and so if licensing staff come out and you've made those changes, they will audit based on that.
Got it. Thank you, Stacy. And I know you mentioned, Stacy, that you also have seen the chat come in, so please feel free to answer any questions you think you've kind of scrolled through and I'm not getting to. We got quite a few, so we definitely won't be able to get to all of them. But just wanted to just check with you first before I read out the next question.
Okay, let me no, I think I was looking at the beginning one, so I think you've hit most of those.
Okay. I know we do have a couple of questions. Folks are trying to imagine what you know, kind of the progress note version of it, right? There was some discussion, and I know when we did this last year about, you know, the ability to, in some instances, document treatment plan in the kind of the progress note, especially maybe around medication only and others. And I know we have a number of questions that folks are trying to figure out what that would look like. I'm not sure we can really go too much into, you know, because I think it would vary based on your EMR, EHRs, your system. But, you know, I guess one of the questions that we got, does it have to be a separate progress note, or could it be embedded in, you know, I met today with so-and-so, you know, we renewed the medication, so, you know, is doing well, I will see them in 3 months, and then if they even need to make any changes to the treatment plan, or does it have to be kind of 2 separate notes? I guess that's a very detailed question, and I don't know if there's an answer for that.
No, I think kind of along what you're saying. I think it will look different for each agency based on electronic health record, based on how your agency would like it to look for your own internal audits for quality. So I think we're allowing for a lot of flexibility in that area. I think one thing to consider in that is, if licensing is coming in, or I guess potentially OMIG is coming in to look at your charts, how will they be able to identify it, and or how will you be able to help them identify it? So the progress notes technically could be all in, the continuation of date range order, but you might want to say at the top of it, like, treatment planning goal, or you might want to say psychiatric note, medication only, something just to help indicate specifically what that progress note may be addressing beyond just the services that are being provided, so that you and all staff can easily go in and identify those different areas that might be being looked at for licensing staff, or, for example, OMIG. So I think it will be flexible. And I want to say that also, as we move forward and people start to do this and make those changes, we will be interested in hearing what agencies are doing and how you're seeing that work. So I think this is going to be something that will additionally get feedback from you as well.
Thank you. I think maybe we have a time for one more question, and I think this is more about if there's a change to this in regards to the new regulations, and this relates to if a person does not come back after maybe the assessment or within the 30 days of admission, do agencies still need to do the treatment plan? And I don't know if there is a change that happened. So I guess the question is, do you need to do treatment plan if the person does not come back after the admission?
It's funny, I was just reading, I think, the same question at the same time. So it is a good question. There definitely has been no change in that. As you guys know, we've been talking about return to treatment and those things, and that's even a little bit separate. In this case, if somebody doesn't come back, the best way for communication to somebody reviewing the chart is documentation. So if after 30 days somebody hasn't come back, and for whatever reason the initial treatment plan hasn't been able to be completed, you would just want to write documentation. I mean, the treatment plan is really supporting treatment for the individual and the billing of the services. So if they haven't come back, you're not, if you don't have the treatment plan, it's not affecting either of those things. But again, best way to manage that is really just the documentation around it. So that way, if they end up coming back the 40th day, and you're just kind of continuing, to move forward with the individual and going to do the initial treatment plan, there is documentation of why that initial treatment plan might not have been done within those 30 days. And I would also say, and I wish Kelly was able to be on to answer this question, because I think there's another way to look at it, that really an initial treatment plan can be very simple. And you may know, based off of one appointment with somebody, the one area or goal they may want to work on, and obviously that will develop and change over time. But you might be able to say for an initial treatment plan that at your first appointment you had a discussion about a particular goal area, and that is the one area, the one goal that you would write in that initial treatment plan. So we're not necessarily needing you to list in any initial treatment plan the 50 goals that might need to be worked on by somebody, and really more focusing it on that person-centered, individualized, potentially one goal area that you might want to address.
Excellent. Thank you for that, Stacy. So just being mindful of time, we have to.
I'm not sure if you can.
Oh, go ahead, Kelly. You're back. Yeah, we can hear you.
Oh, good. Perfect timing, Kelly, because this is your question.
Well, there's a bunch I want to chime in on, but I'm hearing some feedback, so I'm not sure if you can hear me okay.
Yeah, I also just want to be, we could hear you, but we also have literally a minute left, I think.
Yeah.
But
so
yes.
Regarding OASIS, we are working very hard to align with them. So that was one question. Yep.
Definitely. Is there anything else you would like to quickly cover? I know, unfortunately, technology didn't work well for you.
We're at 1 minute. Yeah, we're at 1 minute. I'll leave it for now. Any other questions? Okay. I'll turn this slide back over to Bonnie.
Yeah, so I think what we just wanted to make sure, again, Stacy mentioned that, these standards of care anchor elements go in effect July 15th. We are, looking to do more offerings, so stay tuned for future offerings. And I think as was chatted in, and as we have mentioned, please continue submitting your questions. And we have both the adult clinic contact and for the children clinic. Please feel free to also contact your field office or central office, and we have the contact information on this slide. So with that, I'm just going to say, since it's 1 o'clock, thank you to our state partners for today's presentation, and thank you all for joining today's webinar. Thank you, everybody.